Hi, everybody. This is Dr. Scott Zeller. I'm an emergency psychiatrist. I'm vice president at the multi-state, multi-specialty physician partnership Vituity. I'm also a professor at the University of California, Riverside School of Medicine. I'm past president of the American Association for Emergency Psychiatry and past chair of the National Coalition on Psychiatric Emergencies. And what I'd like to talk with you about today is the phenomenon of agitation, which is a huge issue in both mental health facilities and also hospitals and emergency departments around the country. Really a very impactful disease state that maybe has not been studied well enough and has been resorting to traditional and coercive ways of working with it historically. So let's start, and this is going to be the first of a series of videos. And let's first just talk about agitation and how it impacts on healthcare systems. So first off, to understand is agitation is a behavioral emergency. And when we say that, we can describe agitation as excessive verbal and or motor behavior that includes hyperactivity. It might lead to clenching fists, pacing about, all the way up to aggression and violent behavior. That's what we call psychomotor activation. There's also mood lability, where people can get really angry, or even the opposite, just start laughing in a very derogatory, hysterical way and shift between those very quickly. They can be verbally abusive, especially towards staff and colleagues. What kind of terrible place is this? What idiot goes to this kind of hospital? And that can go up to very vulgar verbal abuse. Aggression is the one thing we definitely want to avoid. That's when people start to get threatening and even violent. And that's when you hear about these unfortunate cases of agitation in healthcare settings that can lead to some really unfortunate outcomes for people. Basically, because when we get to that level of agitation, there's a big potential to harm oneself, but also to harm others or harm property. This is not a rare situation. A study about 20 years ago said there were likely 1.7 million agitation episodes in hospital medical emergency departments every year. We're guessing with the increase in volumes and the other things we're hearing that number's probably doubled by today. One thing to really understand was agitation is a wide spectrum. If we broke it down really simply, it would be mild, moderate, and severe. What we know is that there's usually a prodrome where people start to become agitated, then they're in that mild to moderate stage. What we want to do is have some really good techniques for recognizing symptoms of agitation and intervene as early as possible before they get to that severe stage, because that's when bad things can happen. So when we think about the costs of agitation, they can be really severe. There's a good study out there that shows that there's the average of 8 really serious patient-to-staff assaults per hospital annually in the USA. And some hospitals will have 25 or even much more assaults that are patient-to-staff assaults. And these aren't just somebody saying a nasty word to one of our patients. They're actually people physically attacking others and causing harm enough that somebody misses work as a result. A lot of times people think of agitation and aggression as a random occurrence that they can't predict or is more criminal behavior. But interestingly enough, in some studies, they've shown that there are a great number of those random assaults, but about 2/3 of them occur during people trying to produce a coercive response or calling a code in response to an agitated individual, trying to contain them and put them into physical restraints and give them an injection of heavy sedating medications. So we see that most of the staff injuries, patient-to-staff assaults occur during that containment procedure. So if we can find a way to reduce that possibility, we're going to have a far fewer staff injuries and far fewer bad outcomes from agitation. Because of all this, there has been, over the last couple of decades, a major call for change. We know that regulatory agencies like the Joint Commission and the CMS have said that physical restraints are not good for the patient, not good for the staff, and for the facility. These are things that we need to reduce in our engagement with people suffering acute behavioral emergencies. And we've seen a lot of hospitals make some really innovative and revolutionary changes to address these concerns and really improve their way of dealing with these folks. But unfortunately, what we're still seeing far too many hospitals around the country is that their method of treating agitation is what we would call restrain and sedate. Basically, let's tackle this person, let's put them in physical restraints, let's give them 3 needles until they're obtunded or unconscious for many hours later. And because of that, we need to have a much more discussion about effective and alternative management of agitation. And that's what we'll be discussing in these videos. So to sum up, the key points of our introduction are, 1, to recognize that agitation is a significant issue in healthcare settings, which is it's seen millions of times per year in emergency departments and psychiatric units and other hospital locations. It's a wide spectrum, though. Agitation is anywhere from mild to severe, and our goal is to intervene as early as possible, hopefully when somebody's still at mild agitation before they proceed to moderate or definitely before they get to a severe agitation. And while we know agitation can cause staph injuries, most of those injuries occur when we're attempting to put people into physical restraint. And since all the advocacy and regulatory agencies are endorsing reducing restraint use, we should discuss effective alternatives for management of agitation instead of our traditional fallback method of restrain and sedate. Hi, everybody. This is number 2 of our video series on agitation. It is titled Assessing Agitation, Medical Evaluation, Rating Scales, and Differential Diagnoses. So let's start with medical evaluation and triage. Let's say an agitated individual is in your triage area or in your emergency department in general. What are the kind of things that you need to do a good medical evaluation of this patient who's presenting with an apparent behavioral health emergency? Recognize at first that screening for mental health patients is not something that needs to be overexhausted. You don't need to do a head CT on every patient. You don't need to do a lumbar puncture. But you should be targeting what's in front of you, really focusing on that presenting problem. And our goal in evaluating somebody with a behavioral emergency is to really make sure that there's no comorbid serious medical problem that's causing this, and realize that that's often the case. A lot of our patients who present with acute behavioral emergencies, including the ones that they're considered dangerous to self or others, often can be symptoms of medical conditions that are mimicking psychiatric conditions. And sometimes those medical conditions can be really potentially dangerous and even lethal, and so we need to rule them out. Sometimes it's as simple as somebody having a low blood sugar, and we can correct that easily. And how much better is that than just assuming it's psych, putting them into a room by themselves and coming back the next day to find out that you have a really bad outcome as a result. So we don't want to think that patients are quote unquote just psych. We have to recognize that the brain and the head are parts of the body as well, and look at people presenting with behavioral emergencies as a whole person, and definitely rule out anything that might be causing what appears to be psychiatric symptoms, but are really just symptoms of an unusual medical condition. So what we want to do is evaluate for any kind of causative factors. We also want to help to stabilize psychiatric condition without resorting to restrain and sedate. And we also want to fulfill our EMTALA obligations with the hospitals. EMTALA, the Emergency Medicine Transfer and Active Labor Act, is really a very simple concept that's federal law, which is anybody who is requesting assistance within 250 yards of a hospital needs to be assessed to be determined if an emergency medical condition exists. And if one exists, they need to be given stabilizing treatment or admitted to a hospital without questioning if they have the ability to pay. That's basically EMTALA in a nutshell. The key thing about all this is that EMTALA says that psychiatric emergencies are medical emergencies. So if you evaluate somebody and there's a psychiatric emergency present, that means you have to do the same kind of things you do as if somebody was coming in after a car accident or having chest pain or something like that. So what does that mean in terms of your screening and your essential triage for emergency psychiatric patients? Well, first off, you need to take a good look at what's the presenting problem. Are they suicidal? Are they agitated? Are their friends or family really concerned because of their behaviors? Does it seem like they're doing things that are putting their life in jeopardy or others' lives in jeopardy? Getting the pertinent history right around that presenting problem. You don't need to sit down and say, have you been a smoker for X number of years? I mean, that can all come later. This is triage. Let's really focus on what the presenting problem is and make sure that we're addressing the issues and prioritizing people with severe symptoms as opposed to just lumping them all in. Oh, this is just psych. They all get the same level of care. Vital signs are really important. We find that a lot of those medical mimics of psychiatric conditions can be identified just by vital signs that are outside of the normal range. Tack onto that your visual evaluation where you are able to determine, is somebody diaphoretic, for example? Do they have a tremor? Do they have pupils dilated or constricted? And when you start doing all this, you also want to make sure that you're determining what kind of level of observation you have. Usually, if somebody's having a psychiatric emergency, you want to have a high level of observation, at least direct observation while they're in an emergency setting. A big question that comes up often is, do we need to do laboratory work on our patients? A lot of inpatient psychiatric facilities request laboratory work before they will even consider accepting a patient. The key reason for that is that they need a baseline for their hospital because maybe they don't have great access to phlebotomy or blood laboratories. So that's why they're asking for that. It's not to determine whether or not a medical problem is present. There's plenty of studies out there that show that if an emergency medicine attending doc does not feel that the condition in front of them requires a certain lab test, the chances of just doing that lab test anyway and it showing anything is close to zero. So remember that already our patients having psychiatric emergencies might have the equivalent of the worst day of their lives. And if you're just going to force them to get their blood drawn for no other reason than that you think it's going to be required, you're just making that day that much worse. A lot of our patients are understandably very frightened of pain and needles. So maybe just restrict the laboratory work until it's really necessary, or if you think that it's indicated from the symptoms you're seeing in front of you, or until you feel somebody needs to be referred out and it's required by your exit facility. Also, having some real basic assessment tools for psychiatric conditions is very important. And when we're talking about agitation, this is in addition to what you may already do in your hospital. Most hospitals are required to do a danger to self suicide screening, something like the Columbia Suicide Severity Scale. That's pretty well known. But we find that if you're able to assess for violence and for level of agitation and aggression, it can be really helpful because instead of having a member of your staff or a nurse come to you and saying like, well, Mr. Smith is doing this and he's doing that, and this is what we're seeing, so what do you want to do? How about instead they came to you and said, oh, Mr. Smith is a BARS 5, what should we do? If you're assessing for violence, the Brosset violence checklist is a really good one. Isn't that much more easy to communicate? Everybody knows what you're talking about, and you can respond in a way that makes sure that everybody's safe and you give the proper intervention. That's why these tools are great. And in the clinical setting, the BARS scale is a really simple 7-point scale, which has 100% inter-rater reliability, meaning that once you teach this 7-point scale to your staff, if somebody says this person is a BARS 5, everybody knows exactly what you mean. So it's a really nice thing to use, and it's been recommended by a number of different guidelines on interventions in agitation, including the Project Beta Best Practices in the Evaluation Treatment of Agitation was a big supporter of using the BARS scale. It's free to use, and it's being used by thousands of hospitals worldwide. Basically, I think everybody should go ahead and include the BARS as part of your initial assessment of behavioral health patients. So understand that there are these number of medical conditions that can mimic psychiatric illnesses, head trauma, any kind of like CNS infection like encephalitis or meningitis, a lot of different metabolic situations. We mentioned hypoglycemia, but even abnormalities in sodium or calcium can do this. Poisoning can cause different situations. Always good to rule that out. It's good to get O2 saturation levels because hypoxia can make people seem confused, disoriented, that you might think is psych. We know that hyperthyroid conditions are going to cause a lot of symptoms that are similar to mania or psychosis, seizure. These are big issues. The good news is that they're fairly easy to rule out, but you need to be considering them so that you can rule them out. So, in summation, we have some key points. Number one, screening for mental health patients does not have to be overexhausted. You don't have to throw out all the stops, do a head CT, do every lab in the book. But what you should do is really be considering what's going on, what are these symptoms, what do I need to rule out, and target your screening based upon that. You should be sure that there are no causative or comorbid serious medical conditions to that psychiatric emergency, because those can even be life-threatening. And then finally, screening tools for agitation and violence can be very useful for being able to communicate with your staff and really rapidly assess the level of agitation and risk of violence in patients you're seeing. Hi, we're on to video 3 in our agitation series, and this video is on the psychiatric diagnoses in agitated patients and how we discriminate between delirium, dementia, and psychotic disorders when we have somebody presenting with agitation. So when we're seeing folks in emergency settings, it's important to distinguish the characteristics of delirium, dementia, and psychotic disorders. And we can really break those down simply into a table: what the disorder is, what the distinguishing feature is, the associated symptoms that go along with those, and what our interventions and treatment course should be. So delirium is at the top of our concern list, and that's because delirium can potentially have some really bad outcomes, including being life-threatening in a matter of hours if we don't intervene promptly. And unfortunately, I know too many tales of patients being thought to be, oh, that's just dementia, or, oh, that's just psych, and they're kind of pushed to the back, and they missed out on some very serious conditions that ended up with some really bad outcomes. But if we're just looking and we're breaking these down into differential diagnosis between delirium, dementia, and psychosis, the key thing that when we're looking at delirium is that there's going to be fluctuating levels of consciousness with really decreased attention. I'd add on to that you might see people focusing on things that almost are out there. There's kind of the classic concept of picking at things in the air that nobody else can see. It almost looks like you're trying to catch a fly or move little floaters away from your visual field. That's pathognomonic of delirium, when people are starting to have those visual hallucinations. And remember that visual hallucinations in general are not seen in the vast majority of endogenous psychiatric conditions. If somebody's having visual hallucinations, you can almost be certain that that's not just a psychiatric symptom, but it's actually either a delirium or some kind of medical condition, such as a poisoning or substance intoxication, that's causing visual hallucinations. Something like schizophrenia doesn't really have visual hallucinations almost all of the time. They tend to be more auditory hallucinations, delusions, things like that. So if you're seeing visual hallucinations, you should really be concerned about ruling out delirium. The other thing about delirium is it tends to have a really rapid onset. Somebody was absolutely fine 4 hours ago, and now they're like this. That should be your red flag that this is a delirium. The other things you're ruling out, dementia and psychosis, don't really happen that quickly. They tend to be more gradual in progression when they are endogenous. Dementia, as compared to delirium or psychosis, is really more on memory impairment. There's very little in terms of hallucinations, paranoia, or delusions, especially in the earlier stages. There is disorientation. Sometimes that confusion can lead to agitation. Then we get to psychotic disorders, which you've seen in illnesses like schizophrenia, some bipolar or other affective disorders. Overall, these are deficits in reality testing. And we will see that folks like this are changing their behavior, very kind of frightened or withdrawing from people, or really starting to have a lack of emotions altogether, what we call apathy. People start having signs and symptoms, maybe paranoia, unusual thinking, magical thinking earlier on, You might have delusions, and you might see dangerous hallucinations, especially command auditory hallucinations. Psychosis tends to be a chronic illness which will have sometimes acute exacerbations, and certainly there can be substance-induced psychoses. So when we're thinking about acute psychosis in general, it's important to differentiate, as I just said, from delirium and other medical conditions, and then get full history and being non-judgmental, trying to take things at face value, not like, oh my gosh, this is the most goofy thing I've ever heard, but actually, what is it that you're thinking? What are you believing? Taking it at face value. If somebody's telling you something that seems really unusual, really out there, don't try to convince them that they're wrong, but rather, oh, tell me more. And that's going to help you really get a full picture of what's going on. When you're in the emergency setting, the most important aspects are really to figure out if that psychosis has changed from what their everyday thing is. So somebody who's never met a patient with schizophrenia, for example, might start talking to them on a park bench and say, wow, this person has some really unusual thoughts and it looks like they're talking to themselves. I better call an ambulance. That might be that person's level of functioning. It may just be how their life is. Unfortunately, people with diseases like schizophrenia have constant psychosis, and that's their baseline, and it does not necessarily improve by what we currently have. That may be just their standard, and they've come to terms with that and figured out ways to mitigate those symptoms as best they can, and they've been doing that for a long time. And as long as they're not doing anything that's dramatically different than their baseline, and they're not doing anything that's causing them to be unable to care for themselves or making them at risk to harm themselves or others, it's not an emergency. So just having psychosis, just having schizophrenia is not an emergency. It's not a reason to be brought to the emergency department or hospitalized. But if somebody is having marked change in symptoms, hallucinations have gotten more pronounced, hallucinations have become command hallucinations telling them to do bad things, yes, that's an emergency, and that's where you want to intervene. The treatment course of each of these is dramatically different. With delirium, you need to find out what the underlying cause is and treat that, because if you're able to do that, most cases delirium go away. If you're working with dementia, unfortunately, dementia is a progressive disease. There's not a whole lot you can do other than slow its progression, but you're never going to get people back to their premorbid state of functioning. The good thing about endogenous diseases of psychosis is that they do respond well in many cases to antipsychotic medications and other treatments. So it's always worth intervening once you've completed your differential diagnosis. So when we think overall about the differential diagnosis and evaluating somebody having symptoms in the emergency setting, we've got a couple key points. One is that it's really important to differentiate psychosis from delirium and other symptoms of medical conditions which might mimic endogenous psychiatric conditions. Also, recognize that some people live with symptoms of psychosis as just part of their lives. And so having those symptoms are not in themselves an emergency, but they can be an emergency if those symptoms have abruptly changed recently from their typical day-to-day baseline, and especially if those symptoms are now causing them to risk becoming dangerous. Hi, this is video 4, which is about other psychiatric diagnoses in agitated patients, and we'll look at mood disorders and substance use disorders in this chapter. So let's start with mood disorders such as bipolar disorder, especially acute mania. In this day and age, the diagnostic manual says there's bipolar 1 and bipolar 2. More commonly, it's the bipolar 1 mania that you need to be concerned about when it's encountered in the emergency setting. When we're thinking of acute mania, that's going to be people who could have any of the following kind of things: euphoria, irritability, fluctuating anger, even up to rage and hostility, delusions, especially paranoid delusions, hypersexuality, or also hyperreligiosity, especially believing one to have special religious powers or connections. Somebody's hyperactive, they can't sit still, they're just moving all around. They've got rapid speech, very talkative. They can also be very impulsive, and racing thoughts are something we see quite a lot. And if you hear from people, it's like, oh, our family member here has not slept in the last 3 days, that should be a real trigger that this could be mania. Realize that there's lots of great data out there that show that patients with acute mania are really at a heightened risk for suicide, especially when we have what we call a mixed mania state, where there might be symptoms of mania, but also some dysphoria, some depressive symptoms, feelings of being distraught or that their life is not going the way they want to. And they have enough energy to really go ahead and do some dangerous things to put themselves at risk. So it's really important to take a good look at patients with mania and rule out that they're not also acutely dangerous to themselves. And also realize that people who are dangerous to themselves and with heightened energy can also be danger to others, because sometimes maybe the idea comes in your mind, well, I'm going to kill myself anyway. I might as well take out a few people with me kind of thinking. They can really have poor impulse control. I've seen, unfortunately, very, very risky behavior. I have seen in my clinical career so many cases of people who were brought in after doing something that the average person wouldn't do, like get in a car and drive 800 miles in one direction in the middle of the night for no reason, with no destination, and just seeing how fast they could go the whole way. Going out and going into dangerous neighborhoods and shouting inappropriate things or acting in an unusual way, putting themselves really in danger. And there's a kind of a grandiosity that you see where people will feel like they are superhuman and they're impervious to harm. And so why not walk into this dangerous neighborhood and start shouting insults at everybody you pass, because nobody can hurt us? Part of that grandiosity really puts people in danger, and we need to recognize that when we're doing a risk assessment. At that same time, recognize that of the serious mental illnesses, bipolar 1 disorder often has people who are very high functioning when they're not cycling into mania or serious depression. And in fact, we know that there's celebrities and big corporate CEOs who have bipolar disorder, and when they're not in one of their high cycle stages and they're really at baseline and doing it really well, they can be super high functioning. What we found, when you talk to people when they're in mania, they often really remember it, and they still have that level of intelligence that they have when they're not acute. And they often really remember things when they're in remission. So it's important to work with them with that in mind and recognize that don't say anything goofy or something that you think, oh, they won't remember it because look at their condition now. They're probably going to remember it. And they'll remember it was you that said it. So treat them just the way you would want to be treated yourself. Do the golden rule, basically. And move on to comorbid substance abuse in psychiatric conditions. Sometimes it can be really hard to tell the difference between psychiatric type symptoms, whether they're caused by an endogenous condition such as schizophrenia or bipolar disorder, or that these have been induced by using, let's say, a stimulant like methamphetamine or cocaine or other medications. When somebody is having what appear to be symptoms that might be caused by a substance abuse, especially high energy, hypersexuality, behaving in such a way where it seems like they're not thinking clearly, or if they're agitated, angry, lashing out, combative. If you think that it may be substance induced, especially stimulant induced, such as by methamphetamine, it can often be really helpful to not try to just say, okay, this is what this is. Let's treat it right away. This person has schizophrenia and methamphetamine. You may want to give them some time to detoxify in front of you and then make a reevaluation before coming to a final diagnosis. Unless you know something about the patient, I mean, if you've got a positive drug screen for one of the stimulants, which tend not to be remaining in the bloodstream all that long, so it's probably pretty acute, you can go ahead with treating with a substance abuse condition in mind. Also remember, a lot of our folks that we see in the emergency department may have an underlying schizophrenia or bipolar disorder that's being exacerbated by substance abuse. And to see what there really is going on, sometimes giving a chance for them to come down a bit, sometimes treating a little bit with some medications that will help improve their condition as they're detoxifying, will really help us with our overall treatment plan and our decisions on disposition. We should really avoid prejudging what's going on with somebody unless we really have a good idea. We've got either lab data or a good history or a good person who's accompanied to give us collateral history to help us know what's going on and confirm what the condition is. So overall, our key points are to recognize first that there's many other behavioral health conditions that can lead to agitation besides just schizophrenia, definitely acute mania, and certainly a very high percentage of agitation in emergency settings is going to be due to substance intoxication, sometimes substance withdrawal. Recognize that acutely manic patients often have really poor impulse control, and they can unpredictably become a danger to self or others at the drop of a hat without their thinking that that's a problem. Because of their high energy, because of their racing thoughts, they can suddenly become dangerous to themselves or others. So always keep that in the back of your mind. Make sure that when you're working with somebody like this, that you're considering that even though they know not seeming to be agitated, aggressive, or violent at this point, it could happen at any moment, and make sure the staff and everybody else who are around are aware of that. And finally, it can be difficult to tease out symptoms of psychiatric illness when a person is acutely having substance intoxication or in a withdrawal state. So if it's possible to give them a little bit of time to see if there's some detoxification, if that improves their condition, that can be useful and that can help avoid a lot of problems. Hi, this is our next video on non-pharmacologic strategies for managing agitation. And let's really focus on calming techniques, especially verbal de-escalation. So, non-pharmacologic management of an individual who has acute agitation. First, recognize that if we use calming techniques, especially verbal de-escalation, we can avoid the need for physical restraints and avoid the need to heavily sedate people the vast majority of the time. And that's going to help us in many ways and certainly help to lead to more prompt dispositions, getting people on their way to that next level of care. So because of that, it's really worth the short amount of time to attempt verbal de-escalation. And I've had a lot of people tell me, oh, it's easy for me to just write an order for patients to be put into restraints and to give them some parenteral medication. I can go on to my other cases, and we're very, very busy in an emergency department. And I can point out as a comparison to that, well, maybe that's easy for you as the prescriber, but what about the rest of your staff? Because they're going to be calling an emergency agitation code, and then they're going to get a team together and they're going to surround the patient, and they're going to end up doing a takedown where the people are jumping on top of a person trying to hold them down. Patients finally get held down and they get moved to a gurney or to a bed, and they get put into physical restraints, wrists, ankles, one across the belly, held down. The staff member goes, draws up some intramuscular medication, takes some time to get that prepared, and comes back to where the patient's in restraints. They get a team together again so they can hold the person down, so they can pull their pants down and give them 1, 2, maybe 3 injections into their bare rear end. And how much time did that take compared to you saying you didn't have any time, so you just wrote the order? Well, a lot of your staff just spent 10, 20 minutes. Collectively, you're talking about hours of staff time because you felt that you didn't have enough time to try de-escalation for a minute or two. So that's a big difference, and it's worth always the short amount of time to attempt verbal de-escalation. What we know in a really good study is that if you put somebody in restraints in the hospital emergency department, that's going to make sure that they're going to stay on average more than 4 hours longer than people that didn't go in restraints. And what is it worth to you to have that bed available 4 hours earlier with your constant flow of patients coming into your emergency setting? That makes it worth it. That might be a logistical reason or a hospital side reason to do it. The main reason is it's much more humane. It's much more ethical to avoid restraints in individuals. It can be devastating to somebody to be tied down in restraints. And if you don't believe it, have people put you in there and see how it feels. It's a pretty awful and vulnerable feeling to have your arms, legs, and belly tied down and you're not able to do anything and you can't protect yourself and you're very vulnerable. And it's not a great feeling. And if you need to refer a patient with a behavioral emergency out to an inpatient psychiatric facility, they're going to be far more likely to accept that transfer than if you've had somebody who's in restraints. In fact, a lot of psychiatric hospitals, if you call them up and they say, like, well, what's the patient doing right now? And you say, well, they're in restraints. They say, well, call back when they're out of restraints. We don't take people who are restrained. So avoiding that is going to have benefits for the patient. It's going to have benefits for you. It's going to have benefits for your emergency department, emergency setting, hospital as a whole. And if you're not seeing any kind of improvement or chance to keep going after a minute or two of verbal de-escalation, yeah, then go ahead and maybe default to some other things. But always try it, even if people who are really, really agitated. I can tell you from having seen over 90,000 emergency psych patients in my career, it's always worth the effort. And sometimes it will surprise you. The people you thought least would respond to it actually respond to it really, really well. So using de-escalation and calming techniques is always indicated. Hopefully you can avoid getting somebody to that situation where you feel like you have no alternative to restraints. I've seen this note too many times in charts. We attempted de-escalation and it failed, so we went to restraints and medication. That should not be your mindset. The mindset should be, we're continually doing de-escalation, and that's assisting us to proceed with our psychiatric eval, our medical eval, and offering medications. And all these things combined help us to avoid seclusion and restraint. So there's a basic set of concepts to doing de-escalation that are known as the 10 de-escalation commandments. These were created by a brilliant emergency psychiatrist known as Avram Fishkind about 2 decades ago, and they've stood the test of time and are used in hospitals around the world. We could probably do 10 videos on each part of the 10 de-escalation commandments. But for the sake of time here, you can see these on your screen in front of you. Give them plenty of space. Be the person who intervenes. Identify that person's wants and feelings. Be the person who listens. I think if you really had to think about them collectively, the idea is if somebody's agitated, don't be agitated back to them. You be the calm one. Be calm when they're loud. You have your arms at your side while they're clenching their fists. When they're screaming, you're whispering. And by doing that, you're going to have far better outcomes and much more opportunity to get people to take medications voluntarily. Recognize that nobody ever got injured by a finger stick by giving oral meds. You're going to have a therapeutic alliance with patients, generate trust, and actually be able to have a collaborative method of working with people who have acute behavioral health conditions. People are going to get better without you having to resort to calling a code and putting you and your colleagues at risk. If you avoid those restraints and medication procedures, you're going to have far fewer injuries for both your staff members and your patients. Are there going to be times when there's patients who are going to need restraining and forcibly medicating them? Of course. But the vast majority of the time, they don't. And if you're able to work with them and really defaulting to the therapeutic alliance, offer oral meds instead of forcible injectable meds, work with somebody and help them to calm down as opposed to getting the security team together and forcibly putting them into restraints. All these have much better outcomes. The other thing that you want to do with somebody who is agitated is begin appropriate medications in the emergency department. And that's something we're going to talk about in some of the later videos. But recognize that medications in the ED are not chemical restraints, and that you should be thinking of the medications as treatment and appropriate medications. And we'll explain that a little bit. When you're starting medications and you're avoiding putting people in restraints, that can have incredible benefits for your treatment team and your flow and your throughput in your emergency setting. So to sum up, our key points are calming techniques and de-escalation can truly avoid putting people in restraints and avoid giving those heavy sedating meds that can lead to people being unconscious for long hours unnecessarily. Instead, we're going to lead to more prompt dispositions. It's going to be well worth a short amount of time to attempt calming techniques and verbal de-escalation. Remember that verbal de-escalation usually takes far less time than the process of putting somebody into restraints and given involuntary parental medications. When we do give meds in the emergency department, those are not chemical restraints, but instead that's part of a treatment plan. And that's also going to help facilitate a prompt transfer to psychiatric facilities. And it's going to reduce the time in the emergency department. And the time in the emergency department is going to be considered treatment rather than just screen and refer. And by avoiding those containment takedown procedures, we're going to result in far fewer injuries to staff members and patients, and we're going to end up having a much better relationship with our patients as a result. Hi, this is video number 6, which is pharmacologic strategies for managing agitation, and we'll go over some general recommendations and our destination treatment goals that we have for intervening with agitated patients. So number 1, recognize that when we give medications for somebody in agitation, especially when we are using parenteral medications, those are not chemical restraints. And this is far too often a thought that a lot of our colleagues and especially physicians and providers working in emergency settings often, they think that anytime we give an injectable psychiatric medication that's chemical restraints. Well, understand that the Joint Commission's definition of chemical restraints is paraphrased here: a medication used for a condition it is not indicated for, solely to restrict the liberty and freedom of movement of an individual or for staff convenience. That doesn't sound very good, does it? Because the key phrase there is for a condition it's not indicated for. When you're actually treating agitation, that's not a chemical restraint. We should throw that term out because it's a little bit derogatory. When we think about the stigma of mental illness, how many conditions do we say, let's give that person chemicals to? We don't chemically treat a diabetic patient. We don't chemically treat the person with asthma. We give them medications. Well, we're giving medications to people with agitation as well. And that's the way we should look at it. We're treating a condition of agitation. We're not chemically restraining anybody. And we need to get that out of our lexicon and not use it anymore. Well, we know that the medications that we're using in agitation, that there's a number of them that are approved by the FDA specifically for treatment of agitation. And other ones that we use may not be specifically FDA approved, but there's community standards that they've been used for these conditions for years and years and years. So that automatically eliminates the definition that it's a medication used outside of its indication. At that same time, when we're treating agitation, we should go with our non-pharmacologic approaches first, like verbal de-escalation, calming techniques, getting people in low stimulation areas, and then we use medication. And another key point is that patients should be involved in the process of determining what medication they are when they're agitated. Remember that the average agitated person is not incoherent. They're just agitated. So they can actually answer questions, and you can ask them if they might be willing to take oral meds instead of being forced to take a shot. And that can actually be very, very useful. A lot of them can tell you what medication is helpful for them in this stage because it's usually a very distressing situation for them, and they'd prefer not to be agitated as well. It's always worth, if possible, to ask somebody, hey, is there a medication that helps you when things are like they are right now? And you might be surprised the way people respond. So when we're thinking of agitation medications in general, what are our goals? What are we trying to do when we treat agitation? Well, number 1, and this is almost obvious, we want to reduce that level of agitation, reduce those dangerous behaviors, the distress, the anguish that the agitation is causing, reduce the racing thoughts, the hyperactivity, help people feel relaxed, calmer, better control. We want to do that in such a way, though, where there's as few side effects as possible, just like we do with any medication. And let's remember that our goal is for people to calm down, not be unconscious. That's a big difference. There's a lot of folks that think when there's a person with acute agitation, our goal is to see how heavily we can sedate them. But that's really not very useful. Our goal is to calm people, not to knock them out. Calm them to tranquility, not to unconsciousness. Do it in such a way that hopefully you don't have to use physical restraints, but instead create a therapeutic alliance with your patient. And by doing so, that will hopefully help people from getting into those emergency conditions again. What you're seeing now is a algorithm flowchart that was created as part of the Project Beta Best Practices in Evaluation and Treatment of Agitation, medication consideration for the pharmacologic treatment of agitation. This is about 10 years old now, but it's surprisingly still contemporary and up to date. And basically, we really want to offer oral medications for people in all these conditions before resorting to parenteral meds. And some folks might say, yes, but the parenteral meds work faster. Well, not in every situation. Actually, PO lorazepam and IM lorazepam have just about the same time of onset. But even in those situations like many of the antipsychotic medications where there is a faster onset for intramuscular administration than there is for oral, sometimes we're only talking about minutes of difference. And the time that it takes to get all the things going, like get the team together, draw up the medications into the syringe, all the kind of things that are involved with administering an intramuscular med, that takes a lot of time. And if you get somebody to willingly take an oral med in a matter of minutes, they could already be well on their way to being in control of their agitation, while if you were thinking that your only alternative was IM, you'd still be working on drawing that up into the syringe. And as I've said before, nobody ever got a needle stick from offering oral medications. So our key points when we're thinking about using medications to treat agitation is medications are not chemical restraints, but they're appropriate agents that are chosen to treat the disease state of acute agitation. In many cases, these are FDA-approved treatments for agitation, or these are treatments for agitation that meet community standards. Medication goal in agitation is calmness, calming people to tranquility, not to see how heavily you can sedate them. And if you're working in an emergency setting, you have a limited amount of space-time opportunity to treat the individuals you're seeing. You don't have the luxury of knocking somebody unconscious for 16 hours because that's denying the opportunity for other people to get help, and you're not helping the person who is unconscious anyway. So treating with a goal of calmness is going to be far more ethical, humane, and beneficial for our patients. And it's also going to benefit our overall emergency setting and system as a whole. Finally, remember that offering medication is not a separate part of de-escalation, but it's part of de-escalation. And you're doing it as you're using de-escalation techniques. When you can get people to voluntarily accept medication, that's usually far, far preferred. That's a win. Everybody's getting along. There's far less risk of violence or aggression, and you're going to have a much better opportunity to get people to that next level of care than you would if you just defaulted to putting people into physical restraints and forcibly medicating them. This is our next video on the role of antipsychotics in managing agitation, especially in an emergency setting. So there's some key basic ideas when we're going to be using antipsychotic meds in the emergency setting, whether it's a medical or psychiatric emergency setting. Number one, oral meds are preferred. And why is that? Well, easiest thing to point out is it's less coercive. Offering somebody a pill and a cup of juice is much nicer than having them being held down, having their pants pulled down, and sticking a needle into their bare bottom. I don't think there's many people who would think those are equivalent. And because you're doing this less coercive treatment, you're going to have a much better opportunity to create a therapeutic alliance with your patient, which is a really important thing in behavioral health care, that we want to be not seen as adversaries or the enemy of our patients, but as collegial collaborators, colleagues. We're going to help you get better. You're going through a tough time. You're having a bad day, but we're here to make it better. We're going to work together with you rather than I'm the doctor, you're the patient. I'm going to force you to take these meds and you have nothing to say about it. The key thing we've seen from multiple guidelines projects for the past 10 to 15 years now is that second generation antipsychotics are the ones that are preferred for both oral and intramuscular administration. Although these guidelines have been in place, like I said, for many years now, we still see too many places defaulting to haloperidol use in these situations, and maybe because that's what they've been trained, that's what's on their formulary. That's the way that they've always done it. There's also some really, really severe side effects from that haloperidol cocktail, which we just as soon avoid, because once we've given it to a patient and they have severe side effects, I can guarantee you that they're not going to want to get that med again. And if that's your default med, you've just really set yourself up in a bad situation. Dystonic reactions such as oculogyrate crisis, a laryngospasm, torticollis, you might see that about 24 hours after somebody's been administered haloperidol. That can be terrifying for patients. If all of a sudden you have a laryngospasm and you're having trouble breathing and you don't know why, and it's from the haloperidol, and somebody doesn't recognize it at first or there's no staff around, it's a fairly easy thing to turn around, but those moments when the patients have it is terrifying. And even when our patients are taking haloperidol in the emergency setting, or when they're receiving a shot of it, many of them get like a severe dysphoric state afterwards where they just feel miserable for days after getting that shot of haloperidol. Also, once again, always remember that our goal of using meds in agitation is to calm people, to chill them out rather than knock them out. Doesn't help anyone when we heavily sedate a patient. And that haloperidol cocktail, that B52, is really legendary for causing severe oversedation. It's not unusual for somebody given that B52, the haloperidol 5 milligrams, lorazepam 2 milligrams, Benadryl 50 milligrams. That can lead to patients sometimes being unconscious for 12, 16 hours. You can't wake them up with a sternal rub. And sometimes, those folks who work in emergency settings don't even see those side effects because sometimes they take 16 to 24 hours before they present themselves. And the person may have already been moved on to an inpatient psychiatric unit or elsewhere in the hospital or different people on shift and don't recognize the connection. I've had patients tell me they just feel awful, and it's all going back to that one shot. Did we really need to give that haloperidol? Could we have had an alternative? In fact, there was even a Cochrane review that was published in 2017 that said, if alternatives are available, giving haloperidol for agitation could be considered unethical. Well, all the recommendations are for alternatives, so it shouldn't be that hard to avoid it. A lot of our patients, and probably everybody listening to this video has heard a patient tell you, I'm allergic to haloperidol. And from the traditional concept of what an allergy is, they're probably not allergic to haloperidol. But this is the way of our patients are saying to us, I've had haloperidol before. It made me feel awful. I had bad side effects from it. Please don't give it to me again. That's how they're telling it to you when they're saying that they're allergic to it. And taking the recommendation that we should start with second-generation antipsychotics, such as if we have to use intramuscular, it should be olanzapine or ziprasidone. If we're going to use oral, we should be using risperidone or olanzapine or Seroquel in these situations. Now, one thing that along those same lines, there are some new medications that are not parenteral, that are not coercive, that are not forcible, that might be showing us some really, really nice potential good outcomes. And so we'll be talking more about those in a second, but these newer non-coercive medications are sublinguals. We also have meds that are available now that are inhaled. And in the future, we may even have some intranasal antipsychotic medications. Now, one other point to make is that people often will think, well, this person is acutely agitated and they didn't respond to the shot that we gave them of, let's say, haloperidol 2 hours ago. Let's give them another shot of haloperidol. Recognize there's a really close curve between the dosing efficacy and the side effects of medications, especially first-generation side effects. If you're looking at this slide that's on the screen right now, this is kind of a classic set of curves where you see the antipsychotic effect in red compared to the neuroleptic or the side effect threshold in blue. And you can see that there's a certain dose of antipsychotics that you're going to get a really robust response to, and then you pretty much plateau. And giving more antipsychotic, even a lot more, is not going to change the response at all. You pretty much reach the peak at a certain dose when you're not going to get any more antipsychotic effect. However, as you go up in your dose, you put yourself at much higher risk for really, really bad side effects. Like we were talking about, dystonic reactions, akathisia, extrapyramidal symptoms, or even putting yourself at risk for neuroleptic malignant syndrome. The key points of everything we're talking about with medical management of agitation is, again, while oral meds are preferred in general, that's what you should be offering. And you'd be surprised how many patients are going to take them, even when you think that you're going to have to give them forcible medications. And in the case of giving meds for agitation, second-generation antipsychotics are what we're preferring, both if it's going to be given orally or if you do have to resort to an intramuscular parenteral administration. One more time, because I just can't say it enough, because people still seem to think otherwise. The goal of medications for agitation is to calm people without over-sedating them, chill them out without knocking them out, and at the same time, give a med that's going to have the lowest risk of bad side effects. Because if you want to create a therapeutic alliance with the patient, if you're giving a med that causes them to feel awful, horrible, or have really, really bad side effects, you're destroying that therapeutic alliance. And instead of having patients see you as an adversary or an enemy rather than as a colleague or somebody that's trying to help them. And then there is a neat thing that, and we've seen new opportunities for psychopharmacologic treatment for agitation that are now approved by the FDA. These are great alternatives to our traditional B52 or other intramuscular opportunities for agitation. We now have meds that are offered as sublinguals. We have agitation treatment that is an inhaled option, inhaled into the lung. And we're even looking at the potential for intranasal delivery of agitation medications in the very near future. Hi, this is video number 8. This is about the role of these medications in managing agitation, benzodiazepines and dexmedetomidine. Let's start off with talking about the benzodiazepines, especially lorazepam, which sometimes is referred to as the emergency psychiatrist's best friend, because it's useful in really many situations. While being relatively benign, it's fairly well tolerated across the board in most patients, especially when we're using it as a one-time PRN as needed medication. What we find is that the benzodiazepines or lorazepam are often our best intervention when we don't have a lot of information about the patient, when our diagnostic evaluation remains unclear. We know that antipsychotics in general, and even the second generation antipsychotics, which may have a bit fewer risks of side effects or bad outcomes, we know that they still are risky compared to lorazepam. So offering a lorazepam when we really don't know what's going on might give us a chance, buy us some time to have that person calm down, relax a bit, and it may even be the appropriate treatment. And if somebody is in alcohol withdrawal or benzodiazepine withdrawal, for example, it's going to be the right medication to help them calm down. But it's also going to make sure we're giving somebody an opportunity to give us a better time to make a decision about what the diagnosis is and what the longer-term treatment intervention is going to be without the risks that we see in antipsychotics. Recognize that we can offer oral lorazepam, and sometimes I've heard staff come to me saying, this guy really needs a shot of lorazepam, don't write for an oral. And what they don't realize is that the time of onset for oral lorazepam is essentially the same as intramuscular. We do know that other antipsychotic meds, for example, work faster given as an intramuscular than PO, but it's not the case with the lorazepam. So there's no advantage to giving somebody the shot. It doesn't work any faster. And even if staff are thinking that that's the case, you can just reassure them that the time of onset of oral lorazepam and intramuscular is just about the same. And isn't it better to avoid that needle stick, to have a better relationship with the patient? If they're willing to take oral medications, that should always be the way you go with this med. Nursing staff do have concerns at times that maybe a patient is drug seeking or they're manipulating because they specifically want to get a benzodiazepine. That is something that you need to evaluate and rule out, and certainly just don't give the medication out like candy. You can use it as an emergency medication, as a one-time med, and make sure that the staff know that this will not be repeated, especially if you have concerns that this might be a drug-seeking individual. At the same time, if you're only using this as a one-time medication, you're not going to be creating somebody with dependency. You're not really creating a situation where you're making somebody into an addict. There's an exciting new opportunity to treat agitation that's really a different pathway than we've ever used before, and that's one of the reasons it's so exciting. Pretty much for my entire career in emergency psychiatry, which has spanned over 35 years now, when we were talking about treating agitation, we really only had antipsychotics or benzodiazepines available. And in many cases, we're really reluctant to use antipsychotics because they have risky side effect profile, and they also are ruled out for people with dementia, for example, because of the risk of a CVA. They have a black box warning. So because of that, it has been really interesting to see for the first time something outside of the benzodiazepines and antipsychotics that we can use and is now FDA approved for the treatment of agitation, and that's dexmedetomidine, which has been used historically for kind of ICU delirium, but now there's a formulation that's sublingual that is approved and indicated for the treatment of agitation and bipolar disorder and schizophrenia. It's an oral dissolving thin film where you can offer it to the patient. It's not a coercive med. You don't hold them down and put it in their mouth. You say, here's this film, put this in your mouth. It's going to dissolve really fast. They can have a cup of juice or a glass of water with it. And what you see is a really nice improvement in the rating scales for agitation within a matter of minutes, usually 20 to 30 minutes or so. The PEC scale is what's used most commonly to determine response to agitation treatment in pharmacologic studies. The PEC is part of a greater psychiatric rating scale, but it's really called the excitatory component. It's a measure of the things that are causing agitation, which if you break them down, there's 5 different parts: excitement, tension, hostility, uncooperativeness, and poor impulse control. And across those 5 different components, we see improvement in using this new approach, this dexmedetomidine oral film. And what's nice, it has very low risks of side effects. The most common one is somnolence, which some people might even think is a good thing rather than a side effect. Occasionally, but in really small, less than 5%, you're seeing dizziness or orthostatic hypotension. So our key points from this discussion about benzodiazepines and new opportunities for treatment of agitation is that, number one, benzodiazepines are useful in many different aspects of agitation, especially when we don't know all that much about the patient or the causes of the agitation. These meds are relatively benign. They're usually pretty well tolerated in most of our patients, especially compared to antipsychotics. Dexmedetomidine is a new option that's available for the treatment of agitation in a sublingual film formulation with a completely different mechanism of action. And it's been shown to be effective for agitation in patients with schizophrenia or bipolar disorder. And so it's really nice to have a new option for treatment of agitation. So this is our number 9 video in this series on agitation. And we thought it might be helpful to give you a clinical vignette from my own professional career that might help you understand how approaching agitation as an emergency medical condition and seeing that the traditional approach of restrain and sedate is not only really unethical and in many cases inhumane for our patient population, but really, really unnecessary in the great majority of the times. People have historically just kind of defaulted to thinking, well, look at how this person is, their current condition. The only opportunity we have to intervene with them, we have to put them in physical restraints. We have to hold them down and forcibly medicate them with heavy sedating medication. And what else can we do? But let me give you an example of a patient that I had in my career that demonstrates things maybe a little differently than that. So I was working in an emergency department at a hospital, and a patient was brought in by paramedics on an involuntary psychiatric hold. He was screaming nonstop. This patient came in and was seen by the triage nurse, and the nurse immediately said, let's get the team. We're going to put this person, take him right from the gurney, and we're going to put them into a restraint bed here in our emergency setting and put them into a seclusion and restraint room, restrain them in 5 points to the bed in the seclusion room. And the nursing staff came to get me and said, Dr. Zeller, we have a patient who's really, really agitated and he's really in bad shape and very incoherent, and all he is doing is screaming. Can you prescribe him intramuscular medications? Can you give him the haloperidol, lorazepam, diphenhydramine cocktail? Because he needs it. That's what he needs right away. And I said, well, did you ask him if he's willing to take medications? And no, he's incoherent. He's just screaming nonstop. And I said, well, I've got to see him before I prescribe anyway, so let me go talk to him. And so I went to the patient room, opened up the door, and sure enough, there's a patient in there screaming, nonstop. And just decided to go ahead and try it. And so I said, "Sir, when you're having a difficult time like this, is there a medication that might help you?" And the patient was, "Yeah, yeah, 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 yeah." And he stopped and said, "Risperdal." And then, "Yeah, yeah, 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 yeah." And so I caught his eye and said, "Oh, would you be willing to take some Risperdal if we brought you some pills right now and a glass of juice?" And he kind of nodded his head while he continued, "Yeah, yeah, 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 yeah." So I went and told the nursing staff and I wrote for him to get some risperidone and a little bit of lorazepam, both in oral forms. And the staff shook their head like I was out of my mind, but they went ahead and took him that and a cup of juice. And believe it or not, he kind of willingly took the medication. They helped him get it into his mouth. He swallowed it down. And about 30, 45 minutes later, I went back and he was doing much better. There was no more screaming. There was no more yelling. In fact, they were able to take him out of the restraints and he was sitting up in the bed. And I went in to see him and said, "Hey, looks like you're doing much better. It looks like you were really having a difficult time before." And he was able to talk to me at that point. And he said, "Yes, thank you so much. And I know I was screaming and it might have seemed really strange, but what you don't understand is I was hearing these really awful command hallucinations that were telling me to kill my children. And the only way that I could stop them was by screaming, because otherwise I knew that I was going to feel like I couldn't resist them. So I screamed so that I would not hear these command auditory hallucinations, but these voices to kill my kids." And I thought that was just a really, really remarkable thing. And so that even when somebody appears incoherent and in really bad shape and screaming nonsensically, that maybe there's some logic to it, and that we treat everybody as an individual and realize that people are, even when we think that there's no possibility they're going to be willing to cooperate and take meds, our key points that it's always worth attempting offering oral meds, to attempt verbal de-escalation, attempt calming techniques, because our potential benefits and risk reduction are going to be really well worth it. And also, just because a patient's agitated doesn't mean they can't understand you or, work with you collaboratively, or also remember your interactions with them. Be very careful if you think that somebody's, just because they're agitated, isn't going to remember what's going on. They often remember things with crystal clarity, and they're going to remember you're the person who cursed at them or was derogatory towards them. And you certainly don't want that. You should never be doing that in the first place anyway. But our patients can really benefit, and they often remember everything that happens while they're agitated. It's not that they're incoherent, it's that they're agitated. And you can do much, much better by treating the same way you would treat any other emergency patient, with compassion and urgency. So this is our final video in our agitation series, and we're going to use this to just finalize with some take-home messages about agitation, our interventions, our evaluations, our treatment. First off, remember that de-escalation and calming techniques are always our preferred approach to an agitated individual, but that they are not separate from offering medication the vast majority of the time. If somebody's agitation indicates medication, that's part of de-escalation. Don't think of, we did de-escalation and it didn't work, so then we went to medication. No, we are doing de-escalation, and as part of that, we're offering medication. That's part of the de-escalation process. De-escalation is really going to be beneficial, and it's going to help people get to that next level. And if you're even able to de-escalate them to a certain point, maybe you can have a colleague who can take over and you can go on to do that other medical emergency care that you need to do. Next, there's a real tendency from too many clinical locations to kind of still default to the idea, let's put this person into physical restraints and then let's heavily sedate them. Understand that 2/3 of staff injuries involving agitated patients occur during that process of trying to take down the person, laying hands on the person, putting them into physical restraints. But recognize that avoiding taking somebody down and putting them into physical restraints can have lots and lots of advantages in your outcomes, creating a therapeutic alliance, having patients see you as a colleague rather than an adversary, and really being able to work with them, not them trying to resist what you're doing to help, but recognizing that you are helping and you're not the enemy. Avoiding injuring your patient, avoiding putting your patient into a very vulnerable and scary situation, but it's also going to improve safety for that patient and your staff. Recognize that de-escalation efforts typically take less time than what it would take to get the team together, put them into restraints, hold them down to give medications, the time it takes to draw up parenteral medications. So when you think that as a provider, I don't have time for de-escalation, I'm really, really busy, I'll just write an order for them to be put in restraints and seclusion. That might be a little faster for you, but it's going to take combined hours of staff time to put that person in restraints and give them forcible medication. Remember that de-escalation should really only take a few minutes. And after a minute or two, if you feel like you're not getting anywhere, then by all means, you can go to the more coercive treatment. When we're talking about medications for agitation, we should be choosing those based on, one, the efficacy. We want to make people, better and less agitated as quickly as possible, relieve that distress, remove that anxiety, that high energy, the kind of things that are putting them at risk. But we also want to give medications that have the lowest risk for potential side effects. A lot of times our patients are going to willingly take medication, and they'll take the medication that they know works best for them. We should be involving patient preference when possible. Just like if you heard the vignette about the screaming patient, that even though he was screaming, wasn't talking otherwise, that we were able to ask him what medication he would want, and he was able to say it, and then we gave him that med, and it worked really, really well for him. That really helped to create a great clinician-patient relationship, not just for today, but for the future. And we realized that people with severe psychiatric illnesses like schizophrenia and bipolar disorder, they're not only going to be having these symptoms today, these are lifelong illnesses. And so the chances of them coming back to an emergency setting in the future are pretty good. And what we don't want to do is give them the thought that whenever they come into an emergency environment, that we're going to be coercive, hostile, and their adversary, but instead that we're there to help, not to hurt. And when they work with us, there's going to be good outcomes, and we're going to be collegial. We're going to work together. We're not their enemy. Once again, can't stress this enough. The main goal of medication treatment in agitation is calming without oversedation. Sedation is not the equivalent of calming. You don't need to knock somebody out. You want to help them to chill out. Get them to regain control, to feel in command over what's going on. You got somebody who's oversedated to the point you can't wake them up with a sternal rub. They're not able to take care of themselves. You're certainly not able to refer them out to other facilities. You're not able to get consultation to come in. Because if you call for a psych consult and they say, what are they doing now? Well, they're asleep. Well, call me back when they're awake. You're going to have somebody taking up a lot of space in your emergency department for quite a while, a bed that you could be using more effectively for somebody else, because you're not doing anything at that point to help that behavioral emergency patient. It's not good for them. It's not good for you. It's not good for the people in your waiting room. So if you instead have a target of helping people calm down, maybe be a little bit, less active, maybe even a little drowsy, that's okay. But we want them to be able to be engaged. We want them to be able to, if they're hungry, to feed themselves, if they're thirsty, to drink themselves, to be able to answer questions, to be able to work with us so we can get them to that next level of care. And we can't do that with somebody who's unconscious. Realize that, as we discussed, there's a number of medication options now for mostly voluntary, non-coercive treatment for agitation that have become available, including a new option just within the last year to 18 months. So it's an exciting time. There's a number of ways that we can treat agitation that can be taken orally or inhaled or sublingually that can really, really dramatically improve the conditions of people who are in agitation without them becoming aggressive, without there being violence, with really good outcomes that preserve the physician-patient relationship. And I thank you very much for spending time to listen to this series on agitation. My name is Dr. Scott Zoller, and I've been an emergency psychiatrist for 35 years. I'm also have a professor position at the University of California, Riverside School of Medicine. It's been a pleasure to share these thoughts with you, and I hope that you've perhaps changed your perspective on treatment of agitation a bit as a result. Thank you very much.